Hello, I'm Dr. Michael Allen. Thank you for joining me today to talk about brain-based clinical secrets that dramatically control chronic pain. We're going to use primitive reflexes to modulate the human neurologic matrix. Before we get started, let me tell you a little bit about myself. I'm a doctor of chiropractic and a doctor of naturopathic medicine. I've been in practice since January 1977. I hold 4 diplomates, one from the International Board of Applied Kinesiology, another from the American Board of Chiropractic Neurology, one from the Chiropractic Board of Clinical Nutrition, and the 4th from the American Academy of Integrative Medicine. I also have a fellowship in neurology from the American College of Functional Neurology. I've been specializing in chiropractic neurology since approximately 1991, and I use these techniques every day in practice, so I'd like to share some of the things with you. Hopefully you can apply them to help control some of your patients' chronic pain. First, let's look forward where we're going. We'll look at some current research as it applies to primitive reflexes. We'll talk about variations in clinical practice, summation, action potentials, and central integrative states. We'll talk about nociception and pain. We'll talk about a couple of pain control theories, and we'll discuss gravity and how it affects the human nervous system. We'll talk about 12 affects of primary afferentation, posture and motion, and we'll discuss primitive reflexes in the human neurological matrix relative to a couple of videos, one on the asymmetrical tonic neck reflex and the other from the Galant Reflex. We'll also discuss cortical outflow and autonomic concomitants, and then we'll tie it all together by talking about what happens in the dorsal horn of the cord to help control pain. First, a caution. Most of the literature regarding primitive reflexes is unsophisticated. The information that's out there in general is the information that's out there, and it's all worded relatively the same way, but it's not really well educated. So the goals for today's presentation are to help you understand that primitive reflexes can control and can influence pain in a positive way. That these reflexes neither are extinguished or retained. These reflexes last a lifetime. They have a normal display that we need to learn to understand and to demonstrate. And once we know the normal, we'll know absolutely what the abnormal is, because abnormal is anything other than normal. And then also we need to understand that these reflexes make up the fabric of the human neurologic display. Further, aberrant primitive reflexes definitely relate to the perception of pain. Also, I'd like to encourage you to take a new perspective on pain control relative to receptor dependence, and we're going to talk a lot about receptor dependence. But first, let's talk about cortical release signs in psychiatry by Walter Fang and Valakalis. The article found in the Australian New Zealand Journal of Psychiatry in 2005. These authors say neurological abnormalities are reported at elevated rates in neuropsychiatric conditions. They find that cortical release signs are a group of primitive reflexes seen in the neonate and integrate as the nervous system matures. Now let's pause here for a second, because I strongly agree that the cortical performance is relative to standardized input of primitive reflexes, and that these primitive reflexes integrate into the neurologic system as it matures. They do not go away. Continuing here, they say only to later re-emerge in the context of central nervous system disease. I don't think these normal findings of primitive reflexes re-emerge. I think we see the signs and symptoms of a breakdown of cortical controls secondary to primitive reflexes that break down and cause a deafferentation. The research paper goes on here to say that the cortical release signs prevalence in various neuropsychiatric illnesses like schizophrenia, affective disorder, obsessive compulsive disorder, Alzheimer's disease, vascular dementia, frontotemporal dementia, and other neuropsychiatric illnesses allows for their use in clinical management, diagnostic assessment, treatment monitoring, and prognosis. Several issues complicate the use of cortical release signs in neuropsychiatric illness, including the apparent high base rate of some cortical release signs in non-clinical populations. Let's pause here again. Of course, these cortical release signs show up in non-clinical populations. If the primitive reflex performance is anything other than normal, we're going to see an increase in cortical release signs no matter who the patient is. Continuing, they're increasing prevalence with age. Stop again. As age continues and as the primitive reflex display breaks down, we will see an increased prevalence of these cortical release signs with age. Continuing again, the lack of specificity and uncertainty over what constitutes an abnormal response. Well, as I said, an abnormal response is any response other than normal. And the normal with the asymmetric tonic neck reflex and the Galant reflex, you'll be sure and see when we get done here. Here's another paper on cortical release signs in patients with schizophrenia, depressive disorders, and bipolar affective disorder. These researchers wanted to determine the presence of cortical release signs associated with white matter damage. They found that their clinical objective of the study was to determine the presence of cortical release signs in patients with mental illness and cerebrovascular disease, as well as its clinical usefulness given that it indicates cortical damage. That is, the cortical release signs indicate cortical damage. With our patient populations, the ones we see in the practice most often, we're not talking about pathology of the cortex that would relate to cerebrovascular disease, although we do see that. I'm not talking about those. I'm talking about mostly the everyday patient that we see. These researchers reviewed some cortical release signs in 170 hospitalized patients with a mixture of bipolar affective disorder, depression, schizophrenia, cardiovascular disease, and dementia, and found that the signs of cortical release do not have the same importance as cortical damage. And this is important because the signs of cortical release don't necessarily relate to the cortical pathology that these patients would have. So we're talking about physiologic issues, not pathologic issues. However, a physiologic issue can mimic a pathologic issue, and we're going to talk about that in just a minute. From the back of my second book, entitled Receptor-Based Solutions, Functional Neurology Every Doctor Should Know, I say, where primitive reflexes were once saved for the youngest, the eldest, and the most infirmed in society, now functional neurology has revealed their great application in human performance. And I strongly believe that as we influence these primitive reflexes to display themselves properly, we can improve human performance to a greater and greater degree. My friend Walter Schmidt from North Carolina said several years ago, the reason one doctor's technique does not work in another doctor's practice may be that the doctors are employing two very different tools and mistakenly calling them the same things. Well, I think this is true with the primitive reflex information, because the information that's out there insofar as normal is concerned is very good. It's the application that's faltering. As I said, these reflexes do not go away, and that's pretty common in the literature out there that they do go away, but as we'll see, that's false. Let's talk a little bit about summation and action potentials, because that has a lot to do with the primitive reflexes and how they send their signals. First, my perspective in practice is that the entire human nervous system is receptor dependent. The receptors perceive the external environment through the tissues and muscles, etc. And then those receptors send their signals to more rostral centers, and those rostral centers send their efferent response back to the muscles. About 85% of the input to the cortex comes from muscles, but about 90% of the outflow of the cortex goes to organs. It doesn't go back to muscles. So these muscles provide a window into our understanding, but we shouldn't depend on the muscle input because the autonomics tell us so much. This is a schematic of how the muscle receptors stimulate the cortex. So let's look at it, starting with the muscles on the left side. Muscles move joints, joints don't move muscles. The receptors inside the muscles and joints pick up muscle and joint motion and then send their signals to various places. First, the muscle receptors send their signal to the cerebellum. The cerebellum then can unconsciously control muscles to control joints. This is like postural background, for example, spinal muscles that keep us upright relative to gravity. So this is an unconscious movement. And then the muscle and joint receptors send their signal to the thalamus. The cerebellum contributes to thalamic afferentation, and then the thalamus sends their signal off to the cortex so that the cortex can voluntarily and involuntarily control muscles to control joints. So this is a feedback system based on receptor dependence. Let's go backwards. The muscles receive input from the cortex and from the cerebellum. The cortex gets input from the thalamus, and the thalamus and the cerebellum receive their afferentation from receptors in joints and muscles. So if we have a joint and or muscle problem, that is increased spasticity in one area relative to another, we have a deafferentation of the receptor afferentation, which then sets off the cerebellum and thalamus and ultimately the cortex, and it contributes to the muscle breakdown. Further, the thalamus controls the hypothalamus. And the hypothalamus is responsible for things like autonomic control, endocrine control, temperature regulation, sleep and wakefulness, thirst, appetite, sexual behavior, and so much more. But these autonomic responses are influenced by the anterior pituitary through releasing hormones, and then the anterior pituitary sends specific hormones to organs or to glands. Once those organs or glands get the signal, they produce their hormones, and that goes back up to the hypothalamus, which then modulates the anterior pituitary, and we get a hormone balance. Off to the right side, receptors can stimulate hormones, but that's not done very quickly. To the left side here, receptors stimulate the cortex, and that's done right away, almost instantly. So we can influence the cortex, the thalamus, and the cerebellum to control the muscles differently by changing the receptor afferentation. With sufficient spatial and temporal summation, the nerve cell membrane reaches threshold to produce action potentials resulting in afferentation of more rostral centers. And that's very important because it all comes down to sufficient spatial and temporal summation and afferentation to more rostral centers. So here's a cell body of a postsynaptic neuron with its excitatory and inhibitory synapses meeting it. So let's talk a little bit about how these excitatory and inhibitory synapses influence that nerve cell body. The resting membrane potential of the nerve cell body rests at about -55 millivolts, and since it's alive, it wavers up and down, so it's not a constant point, but it wavers around that zone. As the resting cell membrane potential gets stimulation, it rises toward threshold. So here's how it gets stimulation: temporally and spatially. The temporal summation comes from several impulses from one neuron over time, and the spatial summation is impulses from several neurons over time. That causes the nerve cell body to ultimately produce an action potential at the hillock of the neuron, and off goes the action potential to its destination. The excitatory synapse causes a resting membrane potential to rise toward threshold, and the inhibitory synapse causes it to fall away from threshold. And here we see the temporal summation and spatial summation as they cause the action potential to stimulate through the nerve cell body to the axon hillock, and eventually with the action potential being sent. The summation causes the resting membrane potential to reach threshold, and the nerve then fires its action potential immediately, causing a depolarization phase, a repolarization phase. Then when it comes back to neutral, the resting membrane potential is undershot and then comes back to neutral again. And here's the schematics A, B, C, and D about how the excitatory and inhibitory stimuli cause the nerve cell to do its signals, to send its signals. And then, like I said, once it's sent completely. Through the myelinated fibers, the signal travels by saltatory conduction from node to node, in the type 1A afferents, it travels at about 120 meters per second. And from the axon itself, that is the unmyelinated fiber, we're talking about a C fiber or an A delta fiber, that the nerve's transmission may happen at about a half a meter per second or up to 20 or 30 meters per second, but still it's relatively slow relative to the 1A afferents of the muscle spindles. As that nerve impulse reaches its terminal end of the presynaptic axon, the mitochondria there supply ATP for the synaptic vesicles to migrate toward the periphery to release their neurotransmitters into the synaptic cleft so that the action potential can jump the synapse and continue on in the postsynaptic dendrite. If we talk about nociception and pain, this carries on the idea of the nerve signals. We say that nociception is an unconscious and/or behavioral response to certain harmful or potentially harmful stimuli, mostly through the type A delta or C fibers, and these stimuli can be mechanical, chemical, or thermal. Now, it's important to recognize nociception is not the same as pain. Pain is a conscious experience. Pain is a multidimensional complex of personal, private, and emotional experience with numerous sensory and affective, cognitive, and evaluative components unrelated to the amount of tissue damage. Pain is mediated by specific nerve fibers that carry pain impulses to cortical areas of conscious appreciation, and it may be modified by several factors. Pain, or the perception of nociception, is experienced in certain areas: prefrontal cortex, somatosensory cortex, the periaqueductal gray, locus ceruleus, the limbic system, the anterior cingulate cortex, the insula, and a few other places. So here's a schematic representation of how the A delta and C fibers address the spinal cord and can reach somatosensory cortices through the thalamus, as well as the other areas we discussed in the cortex or parts of the midbrain, so that pain can ultimately be perceived. Well, with the invention of the electron microscope in the 1950s, we now know that neurology is based on receptor potentiation, receptor physiology, and not the reticular theory that Golgi and Cajal wrestled with in the late 1800s and the early 1900s. Both doctors won Nobel Prizes for their work, but the electron microscope finally put the whole idea of the reticular theory to rest, and that ultimately put to rest the idea of pinched nerves as well. So pinched nerve theory is no longer an important and viable idea based on joint motion. Sensory receptor function is now at the core of human neurology. So we're going to talk more about sensory receptor function. Pain, it's important to go back here to pain, is a multidimensional complex of personal, private, and emotional experience unrelated to the amount of tissue damage, and it's not recognized until noxious stimuli reaches conscious levels. So there's a couple of pain control theories. The specific theory was the first one. It proposed that specific pain receptors transmit signals to a pain center in the brain, which produce the perception of pain. And this theory was correct in that it perceived that separate fibers for pain eventually carried their signals to the brain, but it was incorrect because it didn't account for the wide range of psychological factors that affect our perception of pain. An excellent example of a soldier on a battlefield who has little or no pain yet has a severe wound, and another soldier who has no tissue damage at all but can be perceiving a lot of pain. So that's how that theory works. The next theory was the pattern theory, and that theory said that pain signals are sent to the brain only when stimuli sum together to produce a specific combination or pattern. But it's incorrect because it didn't account for specialized receptors for pain, nor did it see the brain as having control over the perception of pain. It merely saw the brain as a message recipient. But this theory set up the idea of a gate control theory by Melzack and Wall in the 1960s, which was the accepted and most influential theory to date. They talk in the gate theory about the substantia gelatinosa of the dorsal horn and how that opens and closes the transmission of pain signals so they can rise to conscious levels. Here's a schematic of the dorsal horn and the reception of C fibers and A delta fibers into the rexid areas 2, 3, 4, and 5, the substantia gelatinosa and nucleus proprius, how those signals decussate to the contralateral side and rise to the brainstem reticular formation, to the thalamus, and ultimately the cerebral cortex, and then the outflow there through the periaqueductal gray causes modulation of the pain, especially in the brainstem, and pain is controlled. Well, we're going to talk about a little different idea there in the dorsal horn in just a minute. But before we do, we have to talk about gravity, because gravity is the only constant environmental stimulus. It's always present, and it's perceived in muscle spindle fibers that sense stretch of the muscle as we move about in order to resist gravity. The effects of gravity are not constant, even though gravity is constant. It causes a distortion of the tissues that generate receptor potentiation or stretch. Gravity ultimately influences the thalamus by being constant. Gravity is the stimulus, but proprioception is the modality. Gravity is constantly there, so it drags on our tissues, and it's the perception of that drag through proprioceptors that causes the nervous system to perceive your position in your environment. If you lose the functional relationship of the joints and their mechanoreceptors, you have the probability of losing integrity of postsynaptic neurons and their modulation of other neurons over time. That is to say that for the spinal column, for example, the paraspinal muscles that move vertebrae, if those muscles go into spasm and you have a breakdown or a deafferentation of paraspinal input, then that's going to cause a breakdown in the postsynaptic tissues and a decreased modulation of that postsynaptic tissue over time. The thalamus is the final state of integration before an afferent signal reaches the cortex. Gravity influences the thalamus by being constant. Gravity influences the thalamus through the receptor signals, the highly sensitive 1A afferents, and that modulates thalamic influence, but it's gravity that influences the thalamus by being constant. Every time a primary afferent, or a 1A afferent, enters the spinal cord, there's 12 things that happen. The first and primary thing is that all 1A afferents are excitatory to the intermediate lateral cell column. This allows for the dilation of the arterioles to muscles, capillaries to skin, piloerector tissue, and sweat glands. The next thing to happen is the inhibition of pain, or the excitation of inhibitory interneurons to inhibit nociception. Then these signals must ascend to the brainstem and cerebellum, as well as to the thalamus. These 4 things are all important, but the next 8 are pre-programmed, they're indisputable, and they lead to reciprocity, which is the way that the nervous system, the cortex, and cerebellum appreciate receiving input. The reciprocity is the key. The human nervous system innately and intimately responds to gravity. Primitive reflex dynamics are embedded in the whole human nervous system matrix, and their display is well documented. The clinical significance has until now been limited to the youngest and most infirm, because until now there was no information out there about these reflexes continuing throughout lifetime. There was no information out there on how to examine these primitive reflexes to know what is normal, and then to appreciate abnormal relative to knowing the normal. Here at the Color Atlas of Physiology, the statement that with few exceptions, all activities of the central nervous system, receiving, processing, and integrating information, ultimately find expression in contraction of a muscle. Muscle activity may occur in terms of purposeful motion or of postural control. That purposeful motion is upper body, and the postural control is lower body. There's two different aspects of the way the nervous system displays itself: purposeful motion and postural control, and it's important to know that one is upper body and the other is lower body for the most part. Movement and posture are definitely biased relative to gravity, but movement and posture are not the same thing. The basis of posture is the ability to keep certain groups of muscles in sustained contraction. Variation in the degree of contraction and tone in different groups of muscles dictates the posture of the individual. The muscles that allow for movement should have endurance, that is, they should be rich with mitochondrial endowment. And it's that mitochondria that allows for the production of ATP so the muscles can do their work and relax. But if there's insufficient ATP available, that is, if we have a reduction in the mitochondrial population, then the muscles will tend to go into spasm and not send their signal. As a result, we'll have deafferentation. Now, the last four things of those 8 requirements for reciprocity relative to the 12 afferents to the cord, the lower 4 have to do with the lower extremity, and this is an excellent depiction here of what those muscles should do. So compare this to those reciprocal signals as a result of primary or 1A afferentation to the cord. Here's a person with Parkinson's syndrome, and it represents that a joint that resists movement through a certain range of motion tends to constantly resist movement through that same range of motion. There should be no dividing line between posture and motion, but there should be fluid transition of one to the other. But if a person gets a posture inside of movement, then that's pathology. Deafferentation display can mimic neuropathology by virtue of the motoric effect. That is, deafferentation can mimic pathology. The difference, the former is physiological, secondary to afferent breakdown, and autonomic concomitants, while the latter is the result of frank tissue damage. And we see these postures in practice all the time. These postures are not unusual. This is a series of postures which are part of every movement, but if movement is arrested at any stage, it becomes a posture. Postures are things that you should be able to pick them out in your patient's movement issues. Here's a spastic gait, a scissors gait, a propulsive gait, a steppage gait, and a waddling gait. Most of them have to do with cerebellar signals, but they can also have to do with cortical and basal ganglion influence as well, all causing a breakdown of primary afferentation to the cord. And you can see that these are not reciprocal, and so they're not consistent with the primary afferents that enter the cord, and they're not normal posture. Normal postural control has 3 requirements. You require normal tonus of moderate intensity. Postural tone must be high enough to resist gravity but responsive enough to yield to movement. Further, normal reciprocal interactions for synergistic fixation proximally to allow for selective mobility of more distal segments, and this has to do with shunt and spurt muscle performance. Let's go back to the spinal column again. You must have shunt stability of the spinal column in order to have spurt motion of the upper and or lower extremities. If the spinal column is moving properly, then so should those extremities. But if you have a breakdown of the shunt stability of the centerline spine, then you're going to have a breakdown of centerline structures cortically, and that's what will allow for the presentation of these postures inside of normal movement. And then there's automatic adaptation of muscles to postural changes, like as if to catch your balance, for example. And then number 3, normal reciprocal interaction for control of agonists and antagonists. This is for graded interaction with that of synergists for timing and direction of movement, and then automatic movements for righting and equilibrium reactions, and these are more unconscious responses. Again, these 12 things that affect the function of the spinal cord are primarily the excitation of the intermediate lateral cell column, the arterioles to muscles, capillaries to skin, piloerector tissue, and sweat glands, the inhibition of pain, and the ascendance of the action potential, the nerve signal to the brainstem, cerebellum, and thalamus. And then these last 8 things are all reciprocal, they're ingrained, and they have to happen. If you don't have these things, you have a posture inside of movement. Very important. Let's talk about a new term, dysrecipria. Dysrecipria is a deafferentation secondary to uncoupled reciprocity, which impairs sensitivity and cognitive awareness. Dysrecipria will cause cognitive breakdown or cognitive dysfunction secondary to uncoupled reciprocity. Let's talk a little bit about these primitive reflexes. Developmental reflexes arise at various points during intrauterine life and are regularly assessed in pediatric patients to determine the child's level of maturity and if that child is potentially experiencing any delays. It's been taught that primitive or physiological reflexes are present in infancy and that they last for a few months or a few years when they eventually disappear as the young brain matures, and that they reappear at some future point due to various pathologies. Actually, these pathologies are a disruption of the normal cortical inhibitory pathways. That is, you have a breakdown of the cortical control, which leads to the cortical release of the controls. And an example is the asymmetrical tonic neck reflex that we'll see in just a minute. It's quite common, although mistakenly so, to think that people with special needs have somehow retained primitive reflexes. This is not a retained reflex issue. This is an abnormal display of primitive reflexes that, once it's resolved, should help the cortex, the nervous system, perform in a more natural way. Did I say that once you fix primitive reflexes that special needs issues go away? No, I didn't say that. I said that special needs issues are a breakdown of normal primitive reflex response, and when you reestablish the normal primitive reflex display, the brain can work at its optimal level, but for that patient. It's taught that as the human nervous system matures, the child will no longer demonstrate primitive reflex patterns. Untrue. The primitive reflex patterns will always be there. The primitive or physiologic reflexes have been well known to clinicians for decades, yet it appears to be a little known fact that each of these reflexes eventually fits into the milieu of the human neurologic framework. In reality, there is a difference between dysfunctional primitive reflex display and retained primitive reflexes. The term retained primitive reflexes is archaic. The common medical literature generally teaches that the reappearance of these same reflexes after the first year or two of life is always pathological. If they are discovered in an adult, it can be attributed to fatigue, to too much effort, or following central nervous system damage. Much of this literature, however, is mainly based upon observations, and it's untested in the clinical setting. These unskilled observations are an exploration of neurologic function, but the explorers clearly exhibit an inability to evaluate the reason for some of their own suppositions due to a clear bias that others have previously theorized and perpetuated in literature. Their explanations persist through repetition, but are inconsistent with neurologic research and independent assessment of results. That was the main purpose for writing the book Receptor-Based Solutions. I wanted to teach a quantifiable approach to keeping these pathologies, these dysfunctional primitive reflexes, from gaining a foothold and prevent or at least slow down degenerative changes that lead to the signs and symptoms of neurologic disease. This foothold is established by plastic stimulation to dysfunctional movement patterns, which then become more profound. We need to find them and fix them and turn them around so that there's no more sacrifice of the normal signals, but that we sacrifice the pathologic signal and get the normal display back on track again. So here we're talking about a dysmodulation of the receptor membrane potential if there is a deafferentation and a breakdown of postsynaptic tissue stimulation. That resting membrane potential of that nerve cell body is allowed to rise toward threshold, and you get spontaneous discharge, and that causes these neurons to die quickly. And if you sacrifice in this manner a neuron that should have been stimulated otherwise, that pathology cannot be reestablished. That is, that nerve can't be brought back to life, and that you sculpt dysfunction over time. So let's take a look at tonic neck reflexes relative to normal and abnormal muscle function. Take a look at this.
I'm Dr. Michael Allen, author of the book Receptor-Based Solutions, Functional Neurology Every Doctor Should Know. I'm here today with my niece Emily, and we're talking about tonic neck reflexes. The normal tonic neck reflex is when a patient turns her head to the left side, it should cause functional facilitation of the extensor muscles on the side toward head rotation and functional facilitation of the flexor muscles on the side opposite head rotation. When the patient turns her head the opposite direction, the same thing should occur. Functional facilitation of the extensors on the side toward head rotation and functional facilitation of flexors on the side opposite head rotation. That's the normal response. It's not unusual to see the opposite occur with the functional tests. That is, functional facilitation of the flexor muscles on the side toward head rotation and functional facilitation of the extensor muscle on the side opposite head rotation. This is abnormal. We're talking about the tonic neck reflex in the lower extremity. Hold up, don't let me push down. This is a functional facilitation of the rectus femoris muscle proximally, a straight leg test, and it's checking the lumbar L234 reflex. Turn your head to the right, hold up, don't let me push straight down. The functional facilitation of this muscle, the flexor muscle, on the side opposite head rotation is normal. Turn your head to the right again. Hold up, don't let me push. The functional inhibition of the rectus femoris on the side toward head rotation is also normal because the flexor muscle should be inhibited on the side toward head rotation. A dysfunctional test would look like this. Turn your head to the left. Hold up here, don't let me push. The functional facilitation of the rectus femoris ipsilateral to head rotation is an abnormal response. Head straight ahead. Head to the left again. Hold up, don't let me push. The functional inhibition of the rectus femoris contralateral to head rotation is also an abnormal response because we would expect to find functional facilitation here in this rectus femoris muscle.
So that demonstration tells us that turning the head to the contralateral side from a flexor muscle and causing extension on the side toward head rotation, that's normal. Normal is facilitation of a flexor on the side opposite head rotation and facilitation of extensor on the side toward head rotation, upper and lower body. So if a person has a head rotation to the right side, for example, and they have functional facilitation of a flexor muscle and or ipsilaterally and or a functional facilitation of extensor muscle contralaterally, that's pathology. And that pathology represents a deafferentation to the spinal cord and a deafferentation to more rostral centers and a breakdown of the normal motor response, leading to joint breakdown and an increased perception of pain due to the inability of the type 1A afferents, which should have been performing properly, to stimulate the substantia gelatinosa and the nucleus proprius properly to presynaptically inhibit the perception of nociception in the cord, and the person should have no pain. Similarly, if you have a deafferentation and a breakdown of type 1A afferents, you have the higher probability of 1A afferents breaching the dorsal horn of the cord and rising to conscious levels where we say, ouch, I hurt. Reciprocity is the key here. The normal reciprocal motion relative to the 12 things that happen when a 1A afferent enters the cord. Dysrecipria is a dysfunction of these reflexes, and it can lead to the perception of nociception because the type 1A afferents did not presynaptically inhibit the nociception of the dorsal horn, allowing it to get through and reach conscious levels. The reason one author says these reflexes are retained or that they are extinguished is because they're doing two different things and calling them by the same names. Primitive reflexes are truly at the root of all human hierarchical patterns. Let's take another look at a reflex, this time the Galant Reflex.
I'm Dr. Michael Allen, author of the book Receptor-Based Solutions, Functional Neurology Every Doctor Should Know. Here today with my niece Emily, and we're talking about the Galant Reflex using the hamstrings as an indicator. Hold strong, don't let me push. This is a functionally facilitated hamstring on each side, stroking the lumbar spine just right next to the spine, ipsilateral to the test. The hamstring should be functionally inhibited. We're actually stroking just lateral to the lumbar spine, stroking enough to cause stimulation, but not enough to hurt the patient. This is a similar test to the flexor withdrawal reflex in its intensity on the skin. This is a normal response. Further, normal response is to stroke the lumbar spine contralateral to the hamstring, and you should get functional facilitation of that hamstring contralateral to the test. That's a normal response. The normal Galant test, the usual use is to have a baby tummy down in the doctor's hand, and stroking the lumbar spine on either side should cause the baby to wrinkle up their flank toward the side that's stimulated. That's the normal response. This is a test for brain integrity of the infant to see if they're properly stimulated in their responses. I was at a functional neurologist's office in La Jolla, California, and I was on the table, and he checked my hamstring, functionally facilitated, and he tapped my lumbar spine on the same side as the hamstring, and it was functionally facilitated. And I said, wait a minute, that should be functionally inhibited. He says, no, it should be facilitated. He tapped it again, and it was facilitated. The opposite side, same thing. It was facilitated. So we had a discussion on what we would anticipate. So I came back to my office, and I applied the information for the next 2 weeks on every patient that I saw, and I found that stroking the lumbar spine caused inhibition ipsilaterally, and tapping the lumbar spine caused facilitation ipsilaterally. And I wondered what happens if I tap contralaterally to the hamstring, hold strong, and I found inhibition. So we were both right. It should cause inhibition, but on the opposite side to stimulation. Stimulation of the lumbar spine on the right with a stroking should cause inhibition of that hamstring, but tapping the lumbar spine contralateral to the hamstring should cause inhibition. This is the normal response.
So this test is important because as I apply it, I look at it as a stimulation to the paraspinal muscles and their ability to maintain, endure over time, the ability to maintain upright posture. So this Galant reflex is very important. In my book, I talk about two more Galant reflexes, one T6 and above as opposed to below T6, and then in a standing position, a modified Galant and a ability to test it for upright posture as opposed to prone posture. Very important reflex. Let's talk a little bit about some research. This one's from Clinical Neurophysiology 2016, the control of functional movements in healthy and post-stroke patients, the role of neural interlimb coupling. And this basically talks about the coupling of upper and lower body ipsilaterally, contralaterally, and so forth, that it's a result of non-noxious stimulation, but the point is it's programmable. And so if it's programmable to help improve performance, the dysfunction also can allow a program of aberrant performance and deafferentation. Here we have a paper that talks about reorganization of multi-muscle and joint withdrawal reflex during arm movements in post-stroke hemiplegic patients. This is a paper that talks about rearranging neural architecture with respect to controls. This is a major point because dysfunction will cause rearrangement of neural architecture and help produce a dysfunction over time that will lead to signs and symptoms of autonomic concomitants that are pathological. This impairment seems to occur in single muscles, in single joint, and in multiple joint levels, negatively influencing their spatial and temporal interaction to the joints. It negatively influences the way that the spatial and temporal summation influence the nerve tissue, and it may cause facilitation when there should be inhibition, and it may cause inhibition when there should be facilitation. Can you see how this would influence the dorsal horn negatively if this was deafferentated? That is, if you had signal sent when it shouldn't be and not sending signal when it should, nociceptive signals can then reach conscious levels because they're not presynaptically inhibited in the dorsal horn as they're originally designed to be. Here's a paper on flexion synergy, which overshadows flexor spasticity during reaching in chronic moderate to severe hemiplegic stroke. And again, these are stroke patients, but the same is true when it comes to dysfunction physiologically. The result of disentangling flexor spasticity and flexion synergy in the chronic moderate to severe hemiplegic stroke patient, these researchers found they concluded that flexion synergy is the predominant contributor to reaching dysfunction, while flexor spasticity appears only relevant during unnaturally occurring passively supported movements. And it's that passively supported movement that will allow for spasm to occur when in fact it shouldn't be there at all. Here's reflex circuits from neuroscience and behavioral psychology. In 2016, receptors link musculoskeletal elements to the skin to pathways in the spinal cord through specific reflex circuits. These circuits culminate into spinal pathways that form a distributed network and is organized into hierarchical stages that mediate pattern generation, muscle or motor unit selection, and regulation of mechanical properties of the limbs and trunk. These circuits are subject to task-specific modulation, not only through neuronal influences on interneurons and sensitivity of muscle spindle receptors, but also through history-dependent properties of sensory receptors. It all comes down to receptor stimulation. Deafferentation of receptor stimulation allows for the appreciation of nociception at higher levels and the perception of pain. The key here is to keep the 1A afferents at their highest level, and primitive reflex performance, which can be demonstrated with functional manual muscle testing, is the key to understanding, are these primitive reflexes working or are they not working? The synaptic plasticity and memory hypothesis, encoding, storage, and persistence from 2014 journal Activity-dependent synaptic plasticity depends upon the central integrative state of the appropriate synapses during memory formation and is both necessary and sufficient for the encoding and trace storage of the type of memory mediated by the brain area in which it is observed. Evidence derived from several timely technologies in conjunction with appropriate behavioral analysis continues to offer support for the idea that changing the strength of connections between neurons is one of the major mechanisms by which engrams are stored in the brain. If you change the postural significance of joints and the muscles that control those joints, you will influence the postsynaptic fibers and the way they work. So if there is a spasm in a joint, if you have a posture within a movement, you have a breakdown of that sensory afferent, changing the strength of connection between the neurons, and you'll change the way the engrams stimulate storage in the brain. Cortical outflow and autonomic concomitants are displayed when aberrant metabolic function occurs secondary to a dysmodulation of extrapyramidal outflow. And that extrapyramidal outflow is important because it's based on sensory input from the type 1A afferents. The extrapyramidal outflow goes from cortex through the extrapyramidal system, the basal ganglia, the centerline nuclei in the basis of the midbrain, and it can cause changes in musculoskeletal system, the immune system, cardiovascular system, gastrointestinal system, the respiratory system, genitourinary, psychological, and cognitive effects. It can cause nausea and vomiting and the perception of chronic pain. So it's important to have these autonomic displays appropriately modulated through extrapyramidal pathways through their stimulation secondary to primary afferentation. Here's on the left-hand side, a display of outgoing of efferent fibers, rubrospinal, pontine reticulospinal, medullary, lateral, and medial vestibulospinal outflow, primary sensory, premotor, etc., all the cortical spinal outflow, and how that stimulation affects interneurons, which affect the alpha motor neuron in the anterior horn fiber, anterior horn of the cord, the final common pathway. And the picture here on the right shows how that signal cascades through the midbrain, medulla, and to the cord to cause ultimate modulation there in the anterior horn of the spinal cord. Primary important to get the extrapyramidal system controlled, and that's secondary to the afferents that come from 1A afferents. Let's review. We talked about current research as it applies to primitive reflexes. We talked about variations in clinical thinking. We talked about summation, action potentials, and central integrative states, nociception and pain control theories. We talked about the effects of gravity on the human nervous system, 12 affects of primary afferentation. We talked about postural and motion, primitive reflexes. We talked about primitive reflexes relative to asymmetric tonic reflex display, Galant reflex, and cortical outflow and autonomic concomitants. So how do we put all this together? We put all this together by talking about the effect at the anterior horn cells, the final common pathway, which is an influence of all afferents segmentally from below and from above, causing the motor response at that point. And that motor response can be biased toward facilitation or inhibition, or it can be neutral, allowing the normal response. And all of that normal response is secondary to the signals that come to it from all those rostral centers, primarily stimulated as a result of 1A afferents from muscle, specifically muscle spindle fibers. It's all in response to gravity. My brother Barney came to see me one day. Barney was 14 years older than me. He passed away several years ago. But he sat in my chair next to my desk and he said, "My knees hurt." I said, "How come your knees hurt? What happened?" He said, well, I was walking down the street and I turned the corner and I stepped into a gravity storm. I said, you what? He said, I stepped into a gravity storm. I said, Barney, what's a gravity storm? He says, you know, I fell down. Gravity. Gravity has its influence on the whole human nervous system. We have to be able to respond to gravity in appropriate ways. If the gravitational response is normal, then we know where we are in our environment, and the muscles stimulate the cortex appropriately, and the motor response is appropriate. The organ response is appropriate. We properly nourish the tissues that need to respond to our environment, and that's the autonomic components. If there's a breakdown in the normal afferentation, and if one cortical display outweighs the other side, that is, if we have a hemisphericity of cortical display, that will cause muscles to work in an abnormal manner. It'll cause the cerebellum to cause those muscles to work in an abnormal manner, and we'll start to get a posture inside a a posture inside of a movement, and that's exactly what we're talking about. The breakdown of the afferent signal to cause the appreciation of nociception, because it can breach those dorsal horn barriers and cause the perception of pain. It'll also cause joint breakdown, and over time it'll cause greater pathology, not only structurally but functionally in the organ performance as well. So I hope this idea helped you see pain control in a new light. And it's not just modulation from the periaqueductal gray, but it has to do with reciprocal joint motion. Dysreciprria will show up as a result of inappropriate response to gravity. Let's turn around our patient's response to gravity and make it be appropriate by monitoring these primitive reflexes and understanding better what is normal and treating what is abnormal, to help patients be able to presynaptically inhibit nociceptive reflexogenic efference in the dorsal horn of the spinal cord. I want to thank you for your attention, and I hope this class helped you understand pain control to a greater degree. Thank you very much.